My dear students, welcome on this new session in psychiatry, and this session is going to be about the sexuality in humans and the various related disorders. As far as the human sexuality is concerned, in 1960s, William Masters and Virginia Johnson, they gave a 4-stage model for sexual response. So it's called Masters and Johnson 4-stage model for sexual response, which includes 4 stages of sexual response cycle. These are excitement, plateau, orgasm, and resolution. According to the DSM-4, the Diagnostic and Statistical Manual of Mental Disorders 4th edition, text revision, the recent modification says that there is another stage which is to be included. It's another way of looking at it. And this stage is the stage of desire, basically. Has to be there, and then it follows into the further 4 stages. So the sexual response cycle and the disorders of sexual function are going to be discussed on this module, and we go on to know what are the stages of the sexual response cycle. So look at the slide. Here I include stage of desire as the first stage, and that's the interest in sex and the sex fantasies. They have to be present, then the sexual response cycle is going to occur. And if there's a problem with the stage of desire, then the disorders which can manifest are called hypoactive sexual desire disorder, and it's also called sexual aversion disorder. We move on to the next stage of the sexual response cycle, and that's stage of excitement, during which you get sexual erection. In the females, you get labial swelling, the vaginal lubrication and the tenting, the erection of the nipple, and in both males and females, you get increase in sympathetic activity. If this stage of excitement is in problem, the name of the illness is female sexual arousal disorder. This is called in females. The next one is called male erectile disorder, which is in the males, and this is most common sex disorder in the males, and the factors which are going to precipitate is diabetes, smoking, alcohol, neuroleptic agents, beta blockers, and the tricyclics. The drugs which are used to manage this are sildenafil, vardenafil, and tadalafil. I hope you know all these drugs. These are PDE5 inhibitors, and you also have a prostaglandin E1 called alprostadil. The next stage of sexual response cycle is a plateau stage. And in this plateau stage, the testes move upward, there is flushing of the chest and face, the upper third of the vagina enlarges, and there is sympathetic stimulation. If the stage of plateau is in problem and the plateau is not achieved, then the disease or the illness is called premature ejaculation. And this is the second most common illness, premature ejaculation. I take you on to the next slide, and I show the next stage of the sexual response cycle, which is called stage of orgasm, during which there is expulsion of the seminal fluid, there is contraction of the uterus, vagina, the anal sphincter, and still there is sympathetic stimulation. And if the stage of orgasm is in trouble, then it's called male or female orgasmic disorder, or sometimes it's called anorgasmia. This is more common in females, and this particular stage is also in problem if you use the antidepressant medications, namely tricyclic antidepressants, as well as very predominantly SSRI, selective serotonin reuptake inhibitors. They lead to anorgasmia. The last stage is the stage of resolution, in which there's muscle relaxation, then there's a refractory period required in the males, and then there is return of the sexual activity and the muscular activity and the cardiovascular activity, which takes about 10 to 15 minutes. These are the various 5 stages of sexual response cycle. On the same slide, the last row is not about the stage of sexual response cycle, but a disorder, which I don't have a place to mention otherwise later. That's why I mention it here. It's a different disorder. It's a pain disorder. It's called sexual pain disorder, and it's called dyspareunia, which is more common in the females as compared to males. And also you have another disorder called vaginismus, which is pain associated with severe spasm. So this is about the sexual response cycle stages, and we just mentioned about the sexual pain disorder. Now we go to the disorders of sexual development. Number 1, the first important issue is gender identity. Identifying yourself as a male or female is called as gender identity. And if this is a problem, it's called gender identity disorder, or you call these individuals as transsexual or transgender individuals. They have a normal biological sex, but they have a pervasive and persistent feeling of being born in the body of a wrong sex. So if it's a male, he feels, I should have been a female. Vice versa, if it's a female, she feels it would be better if I would be a male. So it's a pervasive and persistent feeling of being born in the body of a wrong sex. These patients are likely to take sex hormones, or they are likely to go for sex change surgery. In the males, there are decreased androgens in these patients. In the females, there are excess androgens in these patients. And there's altered sexual development of the brain. So this is called gender identity disorder. The next important word in sexuality is gender role. That's the expression of the identity. How a person expresses his sex, how he dresses, and how he presents. The next important area is sexual orientation. Is the preference for opposite sex is called heterosexuality, or the preference for the same sex is called homosexuality. There are two disorders, important disorders to be discussed. One is called androgen insensitivity syndrome, and the second one is called congenital virilizing adrenal hyperplasia. That's CAH. Now we go on to discuss in details the androgen insensitivity syndrome. Look at this. Suppose this patient comes to you. This patient appears to be a female. She has female behavior. When you go for examination, there is female breast development and female hair distribution, and there is female external genitalia, but with a blind vaginal pouch. And because there is a blind vaginal pouch, she reports absence of menstruation. What is this patient? She has genotype XY. She has a genotype XY, and obviously the testes are present. But there is failure of the fetal cells to respond to androgen, and that's why there is no masculinization. Although the genotype is XY, the testes are present, the fetal cells did not respond adequately to androgens, so masculinization did not happen. Whereas there was a normal response to estrogens produced by the testes and the adrenals at puberty. And due to this normal response to the estrogens which are produced by the testes which are present plus the adrenal glands which happened at puberty, this led to development of the breast and development of the hair. So if you look at this particular patient, she has the female breast development, female hair distribution, and she has a female behavior. There is female external genitalia, but there is blind vaginal pouch. Naturally, she doesn't have menstruation. Next, what happened to the testes? The testes descended, and the testes probably came to the labia or came to the inguinal region. And probably this could be the reason the patient came to you with a complaint of swelling in the inguinal region. If you examine the patient, there is no bar bodies in the buccal smear. There is only one X chromosome. So, she has female gender identity, she has female gender role and heterosexuality because the phenotype is female. But there is no menstruation, there is no ovulation, and there will be infertility. So that's a very typical case of androgen insensitivity syndrome, and I said the fetal cells did not respond to the androgens. What's the treatment? What's the management for this patient? The first management is the first complaint for which probably the patient must have come to you is the feeling of swelling in the inguinal region, and this swelling is nothing but the descended testes which are probably in the inguinal region. So surgical removal of testes. This is the first thing to be undertaken, and this is done to prevent the development of malignancy in these testes. Do we need to treat specifically, medically? No, there's no specific medical treatment for this illness. You need to reassure the patient that the gender has many factors other than chromosomes, and this patient can remain a female. She can remain a female, but she is going to be infertile. So you have to go for the further social measures to manage this patient. a lot of counseling is needed, and the surgical removal of testes is the only surgical management which you can do. There's no medical management. So that's about androgen insensitivity syndrome. The second disease on discussion is congenital virilizing adrenal hyperplasia, or abbreviated as CAH, congenital adrenal hyperplasia. What happens in this illness is there's excess adrenal androgen secretion in an XX individual due to the deficiency of 21 hydroxylase. Because the 21 hydroxylase is deficient, there's excess adrenal androgen secretion. The individual is XX, and due to this excess androgen secretion, there is masculinization of the female genitalia prenatally. There's prenatal masculinization of the female genitalia. So at birth, this patient has enlarged phalluses, there's fused labia, and the child will be probably identified, the newborn will be probably identified as a male with ambiguous genitalia. But it is XX individual. When this patient is an adult, the patient suffers from female gender identity, the female gender role, and about 1/3 of the patients are likely to have lesbian sex orientation. So that's about the congenital virilizing adrenal hyperplasia. Now we move on to discuss, as far as the sexuality in humans is concerned, we are going to discuss the drugs and the sexuality. I hope you know the neurotransmitter dopamine has got stimulatory effect, and naturally when there is D2 blockade, or you use the drugs which are D2 blockers or dopaminergic blockers, there's a negative effect. Plus D2 blockade increases prolactin, and there is hyperprolactinemia and galacturia, and there is suppression of libido and erection. As opposed to this, the D2 stimulation, which can happen with sympathomimetic agents like amphetamine, cocaine, there will be a stimulatory effect. Second important neurotransmitter as far as sexuality is concerned is 5-hydroxytryptamine or serotonin. Serotonin produces negative effect on sexuality, and this is easy to remember. The selective serotonin reuptake inhibitors, SSRI, they lead to decreased sexual interest and they delay the orgasm. So anorgasmia becomes an important adverse effect of SSRI. Now if they are going to prevent the orgasm, naturally these drugs could be useful for the management of premature ejaculation. I hope you appreciate. They produce anorgasmia. Naturally, they could be used to treat the premature ejaculation. Now you have a table. On the left side you have an effect, and on the right side you have a drug medication which is responsible. Reduced libido is produced by beta blockers, that's propranolol, that's the effect of norepinephrine. Fluoxetine, which increases the 5-HT, leads to the reduced libido. Methyl dopa reduces central alpha stimulation, and this leads to reduced libido. And the oral contraceptive pills, they can also decrease the libido. Libido is increased by drugs like levodopa, which increases dopamine. Erectile dysfunction is produced by beta blockers. I hope you know this. Beta blockers on long-term use can lead to erectile dysfunction. Methyl dopa can produce this. Obviously SSRI can do this, and the other dopaminergic blockers like thioridazine and chlorpromazine, they can also produce erectile dysfunction. Vaginal dryness is produced by diphenhydramine, which blocks the histamine, and atropine and atropine substitutes as well as pethidine, they decrease or oppose the acetylcholine, so this can lead to vaginal dryness. Orgasm is inhibited, obviously, as we said, by drugs like fluoxetine, which are antidepressants, that's SSRI. Priapism is produced by antidepressants like trazodone, which is a reuptake blocker. And ejaculation is inhibited again by SSRI, that's fluoxetine, plus the D2 blockers in the form of thioridazine, chlorpromazine, and haloperidol. So these were some important effects of drugs, specific effects of drugs on the various areas of sexuality. As far as the medications are concerned, alcohol, marijuana, and nitrites, all these drugs on short-term use, they decrease the inhibitions and they lead to enhanced interest and performance in the sex. So short-term use of alcohol, marijuana, and nitrites, leads to enhanced interest and performance of sex. Whereas long-term use of all these medications, where there is liver damage, it affects the breakdown of the circulating estrogens and it leads to sexual dysfunction. So alcohol, marijuana, nitrites on short-term use enhance sexual performance, on long-term use opposite this sexual dysfunction. Cannabis reduces the testosterone levels in the males. It inhibits the pituitary gonadotropins in the females, so it's going to suppress the sexual function. And opiates like heroin and methadone, they also suppress the libido and they can lead to failure of ejaculation. As far as aging is concerned, there is no significant decline in sexuality with aging. However, the physical changes, they alter the functioning. And this is why arousal becomes more difficult at the older age. In men, there is lower erection, there is longer refractory period and need for more direct stimulation. Whereas in women, there is vaginal dryness, thinning, estrogen replacement, local moisturizers may help this particular situation, or antidepressants might be useful. Now we go on to discuss what is paraphilias. Paraphilia is the preferential use of unusual object or unusual activity for sex. Is para, so it's a deviation, it's a preferential use of unusual objects or unusual activity for sex. This must exist for at least 6 months. Then according to the DSM, you diagnose it as paraphilia. In addition to this patient must exhibit impaired social and occupational functioning. It is interesting to note that the paraphilias are mostly seen in the males. And the etiology might involve developmental psychological disturbance, some genetic factors, and sometimes hormonal disturbances. There are some paraphilias mentioned here. I am describing to you the character of this particular patient and what is it called. And these could be high yield issues to solve your multiple choice question. And if you definitely know it, your answer is going to be 100% right. So I advise you to prepare well on the paraphilias. For example, revealing the body parts or genitals. Revealing, so it's called exhibitionism. Contact with inanimate objects. We said use of unusual objects. Contact with inanimate objects is called fetishism. Heterosexual men with tendency for women clothing. If there's a heterosexual man with tendency for women clothing, is called transvestic fetishism. Basically, it is fetishism because it's an inanimate object. It's just the woman clothing, but it is woman clothing, opposite sex. So it's called transvestic fetishism. Using the low age group children or opposite or same sex for the sexual activity is obviously called, using the children is obviously called pedophilia. Rubbing the penis against a fully clothed woman is called frotteurism. Receiving physical pain, abuse, or being dominated or feeling happy being dominated is called sexual masochism. And the opposite one is giving physical pain or humiliation and obtaining pleasure is called sexual sadism. Giving pain or giving humiliation is called sadism, and receiving pain or abuse and feeling happy is called sexual masochism. Secretly watching the undressing people or people at sexual activity is called voyeurism. There are some more deviations, and the sex activity which is abnormal in some patients, some other paraphilias, is the attraction for feces is called coprophilia. Attraction for enemas is called clismaphilia. Necrophilia is the attraction for cadavers. Only attraction for the parts of the body is called partialism. Telephonic sex is called telephone scotalgia. The attraction for urine is called urophilia, and the attraction for animals is called zoophilia. So all these paraphilias, the different types of paraphilias, are here on the table in front of you, and you can make good use of this to solve your multiple choice question, because there are specific words and you might find the words are difficult, and that's why you need to work on this. Lastly, I want to tell you 5 important P's, the word starting with the spelling P, as far as the sexual history taking is concerned, and this will be very useful to you during your sexual history taking. The 5 P's are history about the partners, that's the first P, partners. Next, prevention of pregnancy in females, protection from sexually transmitted diseases, STDs, and all the history related to the sexual transmitted diseases in past. Next one is the sex practices of the patient, and the last one is past STDs. So there are 5 P's: partners, prevention of pregnancy, protection from STDs, practices of sex, and the past sexually transmitted diseases. So what I did was I tried to concise the issue of the human sexuality, but we did some physiology, we did the stages of the sexual response cycle, and how a 5th stage was added in the DSM TR4. Then we went on to discuss the individual sexual response cycle disorders at each individual stage of the sexual response cycle. Then we went on to discuss what is gender identity, what is gender role. Then we went on to discuss androgen insensitivity syndrome and congenital adrenal hyperplasia. And finally, we went to the paraphilias and the last slide on the sexual history taking. I am sure all this is going to be useful to you. I advise you to make good use of it, prepare well, take a lot of efforts to remember the smaller difficult words on this particular module, and then there's no doubt that you will be successful. I wish you good luck, and thank you very much for listening.